encountered is what to do after yours or someone else's graft goes down, and how do you deal with that situation. My disclosure, once again, doesn't have much to do with this particular topic. Obviously, bypass grafting for treatment of critical limb ischemia is an effective and durable procedure. However, bypasses do include, and patients frequently present with recurrent symptoms. Redo bypass may be difficult due to significant comorbidities, making them poor surgical candidates, although most of the time you can get them through that. The pressing problem is that there frequently is no available conduit. There's obviously increased rates of wound infection and complications. So we tried to look at whether endovascular recanalization of the native vessels is an effective method for treatment of after the patient has already been treated with a lower extremity bypass graft that is now occluded. So we're not recanalizing the graft itself, we're recanalizing the native system. There is some background in the literature regarding this, some also published in JDS in 2009, looking at 24 limbs and 23 patients, all with critical limb ischemia, most with TASD disease and multi-level disease. And the primary and secondary patency rates are listed there. 72% primary patency, 28% primary patency, 72% secondary, with an acceptable 81% limb salvage rate. So we sort of did the exact same study, looking at our own data. We queried our own database, identified patients that had failed lower extremity bypass grafts, demographics, comorbidities, indications for treatment. Procedural information, ABI duplex, were recorded on each patient. All angiographic results were reviewed. And then we tried to compare that, or we did compare that, to a separate group of patients from the same database who were treated with the prior endovascular intervention. I wanted to see if re-intervention group was a more useful comparator. And then we also looked at compared it to patients who just came in for their index procedure. Patients were all treated in the operating room using either fixed imaging systems or portable imaging equipment under local sedation, as we've outlined multiple times today. The intervention type was left up to the discretion of the treating surgeon, so this is not a randomized cohort. This is just looking at our own institutional experience by all the surgeons on staff. Patency, adequacy of flow, and preservation of runoff were confirmed on completion angiography. Procedural success was indicated by less than 30% residual stenosis. Post-operatively, all patients were maintained on aspirin. Patients that were treated with atherectomy or stent placement, and mostly angioplasty patients, in fact, were treated with clopidogrel. And then we looked at their arterial duplex examinations in the post-operative period, looking for occlusions of the treated region, elevated duplex velocities, to find a ratio of 2.5 to 5 as moderate restenosis, and I can just skip ahead to that, but sorry. And ratio of greater than 5 is severe stenosis and treatment failure. And we also looked at clinical follow-up to look for return of symptoms. So in the entire database at that time, there were 2,400 lesions in 1,061 patients. The prior bypass group is a very, very small subset of those of that total group. There's only 43 patients, but a total of 80 lesions. The re-intervention group is listed, and the index group is also listed. Obviously, the index group is much larger. Comorbidities were examined, virtually not statistically significantly different across all groups. Indications were claudication and rest pain and tissue loss. The prior bypass graft group had more rest pain and tissue loss than it had claudication as the indication for re-intervention, although it did have some patients that were re-intervened on for claudication. Lesion distribution is listed. Pretty comparable lesion distribution. There were more lengthy tibial lesions in the prior bypass group. That was the one area that was different. Complications were roughly the same. Same degree of hematoma formation, return to operating room for hematoma evacuation were essentially equivalent. And this is what we noticed. So for patients that were treated for claudication, so had a prior bypass graft for claudication, and then the graft failed and now re-intervened on the presumably SFA popliteal region for most of them. The primary patency was significantly lower than for patients who were treated with either an endovascular first approach or even for the reintervention group. Secondary patency for clotted cancer was virtually identical. Primary patency in CLI, interestingly enough, and you can look at this however you'd like to, were roughly the same for all three of those groups, and you could say that, well, maybe that's actually a decent way of treating those patients, or maybe that method is as bad as treating them that way from the get-go. It just depends on how you want to look at that data. Secondary patency, virtually the same as well, and our limb salvage rate, interestingly enough, is about 80% for the prior bypass group. So I'm going to do a little bit of a quick case presentation just to illustrate how bad some of these cases can be. This is a 63-year-old female, history of hypertension, diabetes, presented with ischemic breast pain and open wounds of the left calf. After 2 lower extremity bypass grafts, details were unknown. Patient was done elsewhere. She doesn't have tissue loss in the foot, per se. She does have adequate contralateral peripheral veins. AVI was 0.43 with flat waveforms at the metatarsal level. Duplex was occluded SFA, POP, PT, perineal, and a diseased AT. This is her initial angiogram demonstrating an occlusion of the SFA, popliteal, PT. There is a reconstituted anterior tibial artery that is not projecting very well on the right side of the screen, but on this image I wasn't able to demonstrate much in the way of foot runoff. So we're able to recanalize the SFA popliteal segment with not too much difficulty, but then could not get through the AT at all to from an antegrade position. There is a reasonable perineal reconstituting there and a diseased but patent distal anterior tibial artery. Obviously, we've presented this a million times now today, it feels like. What else would we do besides, of course, go from below? And that's what we did in this patient. And of course, snared the wire again, and then treated that patient with angioplasty and stent placement for the SFA popliteal lesion, and angioplasty and atherectomy for the POP and AT going down into the DP. It has required 2 other interventions to keep that thing patent, but that's what we've elected to treat her with. So those procedure can be done. It is can be difficult and time consuming. I think the reason I had to go from below was it was a PTFE graft that was done to the below knee popliteal, and for whatever reason my wires and catheters were sort of spiraling in the hood of that graft. I could never find the AT, and coming from below helped that. So at any rate, in conclusion, for a patient that presents with a failed bypass graft in CLI, endovascular treatment is a reasonable option because of the similarity in patency rates when compared at least to other endovascular interventions as first-line therapy. And one should exercise caution before performing an endovascular intervention on a patient with a failed bypass when the presenting symptom is claudication, as there is diminished primary patency, and you can predict that multiple reinterventions will be necessary. Thank you.